Hi, welcome to our Adult Breathing and Sleeping Wellness webinar. I'm Dr. Hillary Knight with Harbor Country Dental in New Buffalo, Michigan. I'm very excited to present this. We've been learning a lot in the past couple months about how our craniofacial development can actually impact our airways and how a compromised airway can actually collapse during sleep, causing sleep apnea, and it affects a host of other bodily systems. So as dentists, it is now our responsibility, according to the American Dental Association, to screen our patients for sleep disturbed breathing. And so we are doing that at Harbor Country Dental, but in addition to that, we now have another treatment option that patients can choose from if they are having signs and symptoms of sleep apnea. So without further ado, let's present our webinar. Okay, so you should be able to see my screen. And actually, let me make sure that I have that on. Good. All right, so I'm sharing my screen. We'll open up that presentation. Okay, sleep better, live healthier. That's our whole idea with craniofacial sleep medicine. So some of you are here because you have noticed some signs and symptoms that can be caused by sleep apnea. And this picture here really sums it up. There's one root cause at the base of the tree, but there are many different symptoms that can present itself in many different ways. Hypertension is largely associated with sleep apnea. Cancer is as well. Headaches, especially upon waking, dry, chapped lips associated with mouth breathing. In children, it can cause bedwetting. For every age, asthma, certainly crooked teeth. And then there are a host of other mental issues that can crop up when somebody is sleep deprived, including depression, anxiety, and ADD, ADHD. So what exactly is a sleep-related breathing disorder? We can define it as a condition of abnormal or difficult respiration when a person's airway becomes partially or completely blocked many times during sleep. And the result of this interrupted breathing pattern is severely fragmented sleep, where the patient doesn't get a full sleep cycle. They get interrupted out of that quality sleep. The constant awakening, even though you're not awake in the sense of you're up and you're conscious that you're awake, but you're at least woken out of that sleep cycle. What that does is that it doesn't give you good quality sleep. You don't get the restorative sleep. And so you wake up feeling fatigued or like you didn't really have a good night's rest, like you want to go back to bed. Usually patients don't wake up fully. They're not fully conscious during these sleep arousals. And oftentimes the patient doesn't know why they're tired. They might blame it on, I had a really hard day at work, or, my dog kept me up in the middle of the night, whatever the case may be. They're not realizing that it's their body that's actually waking them up out of these sleep cycles. Along with sleepiness and fatigue, sleep-related breathing disorders can cause significant physiological and psychological distress. But the good news is that sleep-related breathing disorders are usually treatable, and with the proper diagnosis and treatment, many people have complete resolution of their symptoms. So here's kind of a picture of what exactly is obstructive sleep apnea. So during the sleep, gravity and muscle relaxation allow the tongue and surrounding soft tissues to fall back into the throat area, obstructing airflow. So in this patient here, you see the mouth is open. His tongue has started to relax. It's not suctioned up to the roof of his mouth right here. And as it's relaxing, it's blocking this crucial passageway right here. So this is his air pipe. Now, if he was able to achieve a good proper oral posture, he would have the tongue suctioned up to the roof of the mouth, and he could have his lips together and the air would flow in through his nose, down the airway, and open airway. Okay. Okay, so there's different types of sleep disordered breathing. Some people may just notice it as chronic snoring. We have sleep apnea in the true sense of the word. There's central and obstructive. Central sleep apnea has more to do with the brain chemistry. And so our webinar today is not going to focus on that. That's something that a sleep specialist would deal with. We're going to focus on obstructive sleep apnea. So the picture that I showed you about the tongue obstructing the airway, and upper airway resistance syndrome, or UARS, is similar to sleep apnea, obstructive sleep apnea. But the criteria for grading sleep apnea means that you have to be without breath for 10 seconds, and UARS can be any other range. So maybe you only stop breathing for 8 seconds. Maybe you didn't completely stop breathing, but your oxygen desaturation went down to 80%. So you can have a lot of the same signs and symptoms if you have UARS as you may with obstructive sleep apnea. And so we're going to kind of group those together as sleep-related breathing disorder types. If you did have a sleep study done, you would know that an AHI, or an apnea-hypopnea index, of less than 5 per hour, so less than 5 interruptions, is for a diagnosis not sleep apnea. But 5 to 15 is mild, 15 to 30 is moderate, and severe is over 30 interruptions per hour. That's 30 times that you stop breathing per hour. So what do people with sleep disordered breathing present with? This is a nice little chart. Daytime symptoms: some people get early morning headaches, especially right in the temporal area. Sleepiness during the day, poor concentration. They can be irritable. They can fall asleep during routine activities. Could be watching TV. Could even be having a conversation with somebody. At nighttime, they may experience frequent visits to the bathroom. Restless sleep, choking or gasping for air. They may have a spouse tell them that they've stopped breathing, and they may have very loud snoring. There's a very good video by Matthew Walker about why we sleep, and I'd like to share that with you because as we're talking about, disturbances in sleep, I think it's important to know why we actually need to get a full sleep cycle. What happens in that restorative or reparative sleep that I'm referring to that's so essential for our daily functions. So I'm going to pull up that.
My name is Matthew Walker. I am a professor of neuroscience and psychology at the University of California, Berkeley, and I am the author of the book, Why We Sleep. We certainly know that a lack of sleep will actually prevent your brain from being able to initially make new memories. So it's almost as though without sleep, the memory inbox of the brain shuts down and you can't commit new experiences to memory. So those new incoming informational emails are just bounced and you end up feeling as though you're amnesic. You can't essentially make and create those new memories. We also know that a lack of sleep will lead to an increased development of a toxic protein in the brain that is called beta amyloid, and that is associated with Alzheimer's disease, because it is during deep sleep at night when a sewage system within the brain actually kicks into high gear and it starts to wash away this toxic protein, beta amyloid. So if you're not getting enough sleep each and every night, more of that Alzheimer's-related protein will build up. The more protein that builds up, the greater your risk of going on to develop dementia in later life. What are the effects of sleep deprivation on the body? Well, there are many different effects. Firstly, we know that sleep deprivation affects the reproductive system. We know that men who are sleeping just 5 to 6 hours a night have a level of testosterone which is that of someone 10 years their senior. So a lack of sleep will age you by almost a decade in terms of that aspect of virility and wellness. We also know that a lack of sleep impacts your immune system. So after just one night of 4 to 5 hours of sleep, there is a 70% reduction in critical anti-cancer fighting immune cells called natural killer cells. And that's the reason that we know that short sleep duration predicts your risk for developing numerous forms of cancer. And that list currently includes cancer of the bowel, cancer of the prostate, as well as cancer of the breast. In fact, the link between a lack of sleep and cancer is now so strong that recently the World Health Organization decided to classify any form of nighttime shift work as a probable carcinogen. So in other words, jobs that may induce cancer because of a disruption of your sleep-wake rhythms. We also know that a lack of sleep impacts your cardiovascular system, because it is during deep sleep at night that you receive this most wonderful form of effectively blood pressure medication. Your heart rate drops, your blood pressure goes down. If you're not getting sufficient sleep, you're not getting that reboot of the cardiovascular system. So your blood pressure rises. You have, if you're getting 6 hours of sleep or less, a 200% increased risk of having a fatal heart attack or a stroke in your lifetime. There is a global experiment that is performed on 1.6 billion people twice a year, and it's called daylight savings time. And we know that in the spring, when we lose 1 hour of sleep, we see a subsequent 24% increase in heart attacks the following day. Another question perhaps is, what is the recycle rate of a human being? How long can we actually last without sleep before we start to see declines in your brain function or even impairments within your body? And the answer seems to be about 16 hours of wakefulness. Once you get past 16 hours of being awake, that's when we start to see mental deterioration and physiological deterioration in the body. We know that after you've been awake for 19 or 20 hours, your mental capacity is so impaired that you would be as deficient as someone who is legally drunk behind the wheel of a car. So if you were to ask me what is the recycle rate of a human being, it does seem to be about 16 hours, and we need about 8 hours of sleep to repair the damage of wakefulness. Wakefulness essentially is low-level brain damage.
Very interesting. He's got a great a book called Why We Sleep. That was just a short summary of it, but if you're interested in learning more, it's a fascinating read, so I encourage that. So we could get down into the weeds a little bit about what is an apnea-hypopnea index, but I think I'm going to kind of skip past that. Basically, what you need to know is the difference between an AHI and an RDI is really that an RDI is calculated as apneas, hypopneas, and respiratory effort-related arousals, or RERAs, as they call them, which is an abnormal breathing event that does not meet the criteria of an apnea. Remember, that's stopping breathing for 10 seconds, or of a hypopnea, which you can see defined as a 30% or greater reduction in airflow. But it is still an arousal event associated with the respiratory effort, as you would see on your sleep study. So the patient wouldn't wake up. It's not an arousal in that sense of the word, but it is bringing them back out of that reparative sleep stage. Additionally, when you're stopping your breathing, you're going to see a oxygen desaturation. And so we look at that too. Usually we like to see a 96 to 97% oxygen saturation. And so if it falls beneath that, we call it moderate. Mild. Moderate is anywhere between 80 to 89% reduction in oxygen. 80 to 89% oxygen saturation, and severe is below 80%. What are the effects of sleep apnea on the body? You kind of touched on that at the beginning with this tree that mentions different effects on the body, and also with Matthew Walker's video. But to kind of recap, there can be depression, memory loss, mental confusion, weakened immune system, high blood pressure, heart problems that include irregular heart rhythm, stroke, and heart failure, diabetes, acid reflux, adult asthma, and child asthma, and decreased sexual desire and erectile dysfunction, and most commonly, fatigue. So a lot of body systems are affected. Why is nasal breathing so important? So we talk about snoring as something that, mouth mouth breathing makes you do. You make that snoring sound at night. Why do we want to sleep with our mouths closed and breathe through our nose? How is that going to help? I mentioned in that picture earlier with the tongue at the roof of the mouth, lips together, breathing through the nose. Why do we want that? And the benefits of nasal breathing are numerous. So number one, nasal breathing protects your airway and lungs from airborne particles, and the nasal passage also can warm and humidify inhaled air. Number two, nasal breathing optimizes oxygen and carbon dioxide levels. If you're breathing through your mouth, you're actually expelling too much carbon dioxide. And a lot of people think breathing is only about oxygen, but it's really about the balance of oxygen and carbon dioxide. And we'll get to that in the next slide. Nasal breathing also improves physical and cognitive performance by helping to release nitric oxide. It's a vasodilator that is uniquely produced in the paranasal sinuses, and it lowers blood pressure, boosts the immune system, improves exercise performance, increases brain function, fights erectile dysfunction, and many other health-related issues associated with blood flow. Breathing through your nose also helps with oral health, which we have seen and we're understanding a lot more here in dentistry. If you have a dry mouth from breathing through your mouth, it can lead to an overproliferation of bacteria that causes cavities, bad breath or halitosis, and periodontal disease. I see this a lot in pediatric patients, where they're brushing twice a day, mom doesn't feed them any kind of sugary snacks, and they still have cavities, and we don't know why. And it turns out that they're breathing through their mouth. And so you can definitely see a benefit by learning to breathe through your nose. And lastly, it prevents dry mouth and nasal decongestion. So one of the body's reactions to overbreathing is to produce more mucus if that CO2 balance is off. And so you can actually get more congestion in your nose if you're breathing through your mouth. So it's kind of the chicken and the egg scenario. Are you breathing through your mouth because your nose is congested, or are you congested because you're breathing through your mouth? They tie together. A little bit more on that carbon dioxide oxygen balance. Carbon dioxide is actually crucial. It's required to allow red blood cells to release oxygen into our tissues. Oxygen is very attracted to hemoglobin, and so you need another molecule to then pull it off of the red blood cell and spread it into the tissues. So a couple of things that need carbon dioxide are white blood cells. They use it to attack faster and make antibodies to recruit other white blood cells to warn them of an infection. And CO2 also regulates proteins, numerous proteins within the body, by attaching to the amine groups. Amine groups that aren't protected by carbon dioxide will actually attach to sugars and render that protein useless and in some cases toxic. So structural proteins are affected, hormones, neurotransmitters, and enzymes. If you've seen somebody with liver spots on their skin, that's a toxic accumulation of structural proteins. In the hormone world, poor regulation can lead to the body to release more insulin, which tells the liver to release more sugar, and eventually the patient can develop diabetes. So sleep apnea and diabetes are very closely related. It affects neurotransmitters. Carbon dioxide affects neurotransmitters, dopamine specifically, and melatonin. So you can see depression and anxiety, and you can also see more difficulty with sleep as well. And then, of course, enzymes. So if you don't have the right CO2 balance, your ability to digest food is actually altered as well, and we see patients gaining more weight. So what can you do? What are the treatment options for sleep-related breathing disorders? There's three main options. If you asked a MD, they may only know one or maybe two. So let's explain these a little bit more. The gold standard is the CPAP or BiPAP, which is a continuous positive airway pressure machine. The BiPAP is just slightly different in that it changes the amount of air pressure that the patient receives as they're trying to breathe out. So some patients find that more comfortable, but it's the same kind of idea. You're wearing something on your face. The MAD is a mandibular advancement device. I'll show you a picture of that too. And then the last but not least, certainly not least, is the Biomimetic oral appliance. And that's what we'll really get into here. So here's a CPAP. This patient's wearing it on her nose. Of course, it's attached to a machine that's plugged into the wall. Many physicians consider it the gold standard because it is very effective. The problem is that a lot of patients aren't compliant because of the machine itself. You know, it's bulky. Some patients reject it due to their lifestyles. It's hard to travel. It's hard to sleep next to a new partner and have that on your face. It is difficult to sanitize. It takes a lot of work to make sure that it's clean. And now in COVID era, we're realizing too that it's blowing air into your face. The mask is never sealed, so some of the air gets aerosolized. And if the person using the CPAP is infected, if they have a bacterial or viral upper respiratory infection, it's going to aerosolize that, and that can spread to other sleeping partners and potentially the whole household. So I guess to sum it up, there are some drawbacks, and that makes compliance an issue. So if you look at studies that compare or that evaluate the CPAP's effectiveness long-term, you're going to see that it's not quite as effective over the years, just because people drop off with compliance. And compliance is counted as 4 hours of sleep per night. So as you just saw with Matthew Walker, that's not a full night's sleep either. So there are some issues with the CPAP. So next we have this mandibular advancement device. It's a mouthpiece that's worn on both the upper and lower jaws. And it's made so that the lower jaw is actually pulled forward. You can see it in a person right here. It does help to open the airway and make it so that tongue is not going to fall back into the airway right here. But the problem with this is that you are chronically positioning your jaw in an unnatural position. A lot of patients do find that their TMJ is sore when they wake up, and there actually are relaxer appliances that you can wear in the morning upon waking if you are experiencing that. But it can also change the bite over time, and some patients don't mind it, if it's really helping them with their sleep. So it still is an option, but certainly there are, so I would say, some major drawbacks, and and we always want to do good, do no harm, and I think there are some considerations with this that make it less than ideal. Okay, we just talked about that. Here's an example. This is a patient who was 50 years old. Her AHI was 33 an hour, so she has severe obstructive sleep apnea. And this is what her teeth look like. With the mandibular advancement device, teeth stayed about the same. I'm sure the relationship of the jaws may have changed, but the arch form is still exactly the same. When they did the sleep test without the appliance in the mouth, her AHI was up to 68 an hour. So her OSA got much worse, and that's a strong consideration of what is it doing. Your body's starting to get used to or rely on this appliance. When you take it away, that AHI doubled. Now, she tried a biomimetic device. It only took her a year. You can see that she was 61. And you can see here we're starting to see some change in the palate. So there's some space behind the canines. It's a little bit more of a wider palate. So that's what the device is designed to do. And with no device in her mouth, a year later, her AHI went down to 12 an hour. So now she's in the moderate obstructive sleep apnea range, where she was very severely affected before. So a lot of change in just, I suppose it's almost 2 years' time. So what does the biomimetic oral appliance do? And I'm going to throw in the word here, pneumopedics, with the biomimetic oral appliance, or we'll call it BOAT for short. This is the biomimetic oral appliance. You can see here that there are some axial screws. They have this patented design, and these springs lightly touch the back of the front teeth. This would be an appliance that's worn on the upper arch. You can see there's a split down the middle, and there are some screws that you can turn to widen the plate here. This is different than a palatal expander in the orthodontic sense. Palatal expansion in orthodontics is usually done on developing kids before that mid-palatal suture is closed, and it puts pressure on the suture. So essentially, you're causing some inflammation in that suture, and that causes more bone to be laid down. Well, in adults, we're done growing, so we can't be putting pressure on. So I will show you how it's different. So this screw, you actually turn the key once the growth has already been started. You're turning the key to keep up with it rather than turning the key to stretch the jaw. So it is different. And this is one that's sort of a combination of the mandibular advancement device and the biomimetic oral appliance. The upper appliance is still doing the job of a biomimetic oral appliance, but the lower piece is still pulling the jaw forward. So this would be something that I would recommend for a patient who had severe sleep apnea, and just the appliance alone wasn't going to be enough at first. So we'd still reposition that lower jaw a little ahead of time. But again, you're using it short term until there's a permanent change made. You're not having the patient rely on that for years. So how does this biomimetic oral appliance work? And Vivos is the company that makes it. We explained a little bit already about how it's different than the palatal expander. We're not generating inflammation. Instead, those axial springs that I showed you activate an epigenome, which controls how a gene is expressed. So there's no gene modification here. We're only getting a full expression of your body's own genes. A lot of times genes aren't expressed fully for a number of reasons, and we'll kind of get to that later. But if you could turn the gene on and finish development of that midfacial region, you're going to get more development of the maxilla and allow that mandible to come into its proper position. So we're activating the body's own genomic code. We're just turning that expression back on that was stopped long ago. So the sutures in the skull are plastic. We used to think that they were fused together in adulthood, but there's still plenty of stem cells there, and they can grow and remodel. And so if you were to say, for example, use that appliance on the back of these teeth here, and you're stimulating growth, and we'll take his jaw off now. This whole bone that's yellow here is all the maxilla. The bone is going to grow in every direction where you see it suturing to another bone. So we'll see what that does to the face in just a moment. This is a study that just goes to show what a biomimetic oral appliance can do. They used 15 adults. Prior to the treatment, the average AHI was 45.9. And afterwards, after only 10 months, they showed a 64% decrease in the AHI to 16.5 an hour. So again, you're going from severe to moderate. And that's with no appliance in the mouth. Here we're showing an actual remodeling of the airway, and that's where the word pneumopedics comes in. So this patient wore an appliance for 15 months. The red is where you can see the airflow or the airway. And this patient went from 24 of AHI, which is moderate, to 2.8 just after 10 months. And this is taken with no appliance in the mouth. So again, these changes are lasting. Just a different view. And another view, so this is from mid-skull. You can see the airway here is a lot smaller than it is over here. And some might say, well, that doesn't really visually seem like a lot, but when you're talking about a tube, any change in that width of the tube is going to change the volume of it significantly. So this is just kind of a little graph of that patient. They had a 71% increase in upper airway volume. So that's huge. Here's a patient that went through treatment, and you can see not only is her smile changing, but her face is also changing shape. And that's happening due to the expansion of the maxilla bone. This would be what an arch would look like. So this patient started with severe crowding. You can see that that arch is a V shape. After wearing the appliance for a year, you can see that now she's got these little spaces here, and that space is a good thing. It shows us that the tongue has more room to function. Same thing down here. This patient had their premolars extracted due to orthodontics, and they had a constriction of space. You can see these upper front teeth are kind of tipped backward or inward towards the palate. And with an expansion device, she's getting a little more space back. The teeth are better alignment here in the front, but what we're getting is a wider palate, a better place for the tongue to be positioned. This is a great case that shows not only the change in the jaw, so here's a very narrow, crowded jaw. Here's a nice wide arch form, U shape, no crowding. And you can see the change in the patient's facial aesthetics as well. So here her chin is retruded. And in the final photo, you can see she's got a nice face shape here. She's got more support in these cheekbones as well. And again, facial view, you can see her face is kind of long and narrow, and here it just looks like it's filled out. You know, there's subtle changes, but definitely an improvement in aesthetics. This is another great case where you can see the improvement in aesthetics. This patient had a very small maxilla with crowding. She wore a biomimetic oral appliance, and now she's got this nice wide arch form, well-aligned teeth, and the face support is significant too. This is a good example as well. So this patient came in feeling very tired, unrested. You can see the dark circles under her eyes. She still has good features, but there's just that the dullness. After 3 months of wearing the oral appliance, she could breathe better. You can see that the cheekbones again look more lifted. She's breathing through her nose better. And this is her facial profile. So again, you can see that retruded chin here. And here we come down with the line a little bit more straight. It's a more aesthetic profile. You might say, oh, well, she's wearing better makeup in the second picture. So even if we take that away and we just look at the silhouette, you can see a difference in that patient's aesthetics. And here's her just a snapshot of her CBCT. So what we're looking at here is the angle of the mandible. You know, here was the beginning picture where the jaw was more retruded. The angle of the mandible is very steep right here. But as her maxilla grew out, that jaw was also able to come forward and free itself a little bit. And now you can see that angle of the mandible is a less steep slope there. Occlusal plane has also flattened out. So here it was kind of tipped, and now we're at a flat plane. So she's much better balanced after treatment. So the biomimetic oral appliance can be used for pneumopedics, which I showed you, which is how we treat sleep apnea. So we're doing craniofacial growth to get the airway to remodel and grow larger. But it can also be used for TMJ dysfunction and tinnitus, which is ringing in the ears. It can be used for aesthetics. So even for people who feel like they have an asymmetry in their midface, and it can be used as a way to straighten teeth in conjunction as well. Difference between orthodontics and orthotropics. Orthodontics just means straight teeth. Orthotropics is straight growth. So we're looking at more than just, are the teeth straight? Well, do they have a proper base? Do they have the proper bone support? So that's what we're looking at there. And then it can also be used to correct functional discrepancies. So open bites, cross bites, and speech issues. Here's a great photo of what happens when this is a healthy, normal TMJ, but what happens when this is pushed back because the upper jaw is too narrow, and now the lower jaw has to be retruded in order to stay within the upper jaw. This is actually a dissected skeleton, but you can see here, healthy. Here, this is really retruded. It's very close to the auditory canal here. And there are numerous blood vessels in this area and nerves. And so if the jaw is too close here, it's going to pinch those crucial vessels. And some people hear that as ringing in the ears. And this is a patient who was treated for her tinnitus, and you can see the before and afters. Pre-treatment here, she's positioning her head forward. You can see that the ear is well forward of her shoulder right here. She's trying to open her airway to breathe better. After treatment, after she can breathe through her nose better, that chin comes down. The ear is more directly above the shoulder. She's in better alignment throughout her body because she's breathing better. So not only did her tinnitus resolve, but her whole body's in better alignment. And this is just kind of a cool picture, little subtle change, but this was her arch before she had treatment. You see how this molar is dropped down. And then after treatment, we have a nice even jaw form here. So, her bite was off before treatment and asymmetrical, and with the growth appliance that corrected itself. This is a great case of facial asymmetry. You can see that the patient's right side is a little underdeveloped. This cheekbone is a little high. So she went through treatment a year later. So compare beginning and afterwards. You can see that the midface has broadened and it's evened out. So one eye here is a little bit above the other. Here we're much more level. The nose has broadened because what a lot of people don't realize is that the roof of your mouth is actually the same exact bone as the floor of the nose. And so if you have a really high vaulted palate, you're actually constricting the amount of space that you have in your nasal passage to breathe. So when that the roof of the mouth gets is grown properly and broadens and flattens, you're also getting more space in that nasal cavity too. So here's her CT. Pre is the gray and post is the blue. And you can see she had a lot more growth on the right side of her face because that was the side that was deficient. So again, it just goes back to your body using your own genomic code. There was no force put on her, but her body knew that this side had not had full expression. So she got better facial symmetry. And why is this such a problem? There are a lot of people that have sleep apnea or other related disorders, and why is it so prevalent now? Well, to take us back, most of craniofacial growth happens before we're 2 years old. And so during that time, this just is a great picture to show you, the skull doesn't change, the cranial base doesn't change much as we age. But right here, this midface and the lower mandible is growing forward and downward and out. It changes substantially over time. So by 2 years old, 55% developed. By 4 years old, 73 to 77% developed. And really most development stops around age 12. So those first couple years are very crucial in midfacial development. This is a great YouTube link. I would highly recommend that you watch the story of headgear. But what we've started to learn is that early diet can affect the formation of that midface region quite substantially. And so early breastfeeding and dietary consistency and toughness actually promote proper bone growth, because as that child is using their tongue to function, they are putting forces on the developing bone. Muscle will help to sculpt bone. If that food, that early diet, becomes processed, and which it has after our industrialized societies decided that we needed to puree food to feed to our babies and feed them milk out of bottles, the tongue doesn't work as much, and most of the movement then is coming from the muscles of the outer face. So you're having forces pushed in on the teeth and the developing bone, but the tongue is not being used to push back out again. And so you see not a full development expressed. So the idea here is that malocclusion or crooked teeth is not inherited. A lot of people think it's genes. My mom had crooked teeth, I have crooked teeth. It actually takes 27,000 years for a genetic mutation to be expressed in 51% of the population. So what we've seen in is Dr. Robert Corcini did some studies where he actually looked at rural populations, and after the industrialization and they changed their diet, in that first generation, already 50% of those people had malocclusion. In the next generation, it went up to 70%. In the next generation, 85%. So that kind of dramatic change doesn't happen with genetics. It's dietary and chewing forces that are changing our skulls. And that's why it's happening so fast. And that's why it's happening all around the world where you have industrialized societies. I think it's really interesting to note that in his studies, Dr. Robert Corcini saw that all of these skulls from populations where people were in rural areas, they were isolated, they did not have an industrialized diets, they had perfect alignment of their teeth, and they had room for all 32 teeth. So here's just kind of a picture representation of what I was describing with the forces. So if you're developing properly, that tongue is putting some force up against the palate here. Everything looks good. But if the tongue is low or lazy or not required to work to chew the food, what happens is that the outside muscles of the face are pushing in, and that low tongue is actually pushing out on the bottom teeth. And so you end up getting cross bites, and you end up getting a high vaulted palate. Okay, we're going to take some questions now. Before we do, I'd just like you to know you've learned a little bit more about what craniofacial development is. And if you were affected by sleep apnea and you're interested in taking the next step to have your own biomimetic oral appliance made to enhance your craniofacial growth, we do need to collect some measurements from you. So please call our office, get scheduled for a consultation. We are happy to answer questions. We want to get this information out to everybody. It's a great therapy. Most patients, adult patients, are in it for about 18 to 24 months, and that's wearing a removable appliance for 16 hours a day. If you can't quite make it that many hours a day, it will take a little longer. But the good news is once you're done, you're not tied to an oral appliance that pulls your jaw forward. You're not tied to a CPAP machine that you have to wear on your face every night. Here's our contact information. You can get a hold of us at 269-469-3140. We've also got a YouTube playlist where I've been saving videos that explain craniofacial growth and development. The Right to Grow story of headgear is on there as well, so please check it out. And last but not least, there are some books that I would recommend if you're interested in learning more. The first is Why We Sleep, The New Science of Sleep and Dreams. That's by Matthew Walker, who you saw. The other book is Breath. It's a book that's just recently gained some popularity. The New Science of a Lost Art by James Nestor. And he really delves into some of the oxygen, carbon dioxide balance topics there. But an interesting read. He's a funny guy. Makes it a good book to read. And then lastly, for those of you who may have children or grandchildren or know somebody who's raising a young child and you want to help them understand how they can get proper growth and development, the book Baby-Led Weaning by Gil Rapley and Tracy Marquette is a must read. So it kind of addresses the question of, well, if I'm not to feed my baby purees, what can I do? And the answer is super simple. You just feed the baby things that the adults are having, and you do it slowly and wean off breastfeeding slowly. So there's a lot of good information in there too. I'm going to go ahead and stop the recording now, and we'll take some questions for our live question and answer session. Thank you for spending the time with me. I hope that you're excited to learn more, and we're excited to help. So thank you.